Welcome to session one, where the topic is balancing safety and precision, Zero-Fluoro PFA and TE guided LA closure. We're delighted to start this first session with a fantastic panel. We welcome Dr. Shephal Doshi from Santa Monica, Dr. David DeLurgio from Atlanta, and Dr. Kanj from Cleveland. Now, I'd like to start by presenting a case we recorded at my hospital at St. Bernard's Medical Center in Jonesboro, Arkansas. All right, thank you guys. So the idea is to make sure that we are able to do a concomitant procedure both safely and precisely. But I would also like to highlight how I use my Zero-Fluoro workflow and integrate that into for my PFA, but then still use fluoroscopy for my LA closure. If I can have some help advancing my slides, maybe. There you go. Can I have my next slide, please? There you go. These are my disclosures. So next slide, please. All right. So as I said, I will kind of go through some of my workflow of how I do Zero-Fluoro workflow for my PFA system, which we're using a pentaspline catheter for this case, and how I integrate ICE and mapping into my workflow, and then talk a little bit about what I consider as my workflow for a concomitant case. All right. And again, the question about fluoroscopy comes up. I think as we entered the world of PFA, that was one of the challenges that many physicians faced. Is they went from a low fluoroscopy or no fluoroscopy workflow to a workflow that required a little bit more fluoroscopy, because that is how the system was initially designed. And I think the key, as we learn more about PFA, what we learned is that contact is essential to make sure that we have durable and reproducibly durable lesions. And so that's kind of where I think ICE kind of takes such a big role. And for me, cutting down fluoroscopy was important. And so the way I do this is I use ICE to assess contact, and I use mapping to assess overlap and lesion tagging, et cetera, and then combine the two of them to get this workflow. Next slide, please. So just as we talk about just the workflow for a concomitant procedure, and this is also something that's gained quite a bit of traction in the US, is both LA closure, especially in the high stroke risk patients who are not candidates for oral anticoagulation. I think this is a strategy that has kind of gained a lot of momentum. So, and there are aspects to a concomitant procedure that you have to keep in mind, starting from whether you need pre-procedural planning, and we can have a discussion during panel about what everyone's workflow is. But for me, I think I like to have pre-procedural planning if I can. Thinking about venous access, how are you going to integrate your PFA catheters or sheets and change it over to your LA closure sheets? And then what do you do with your transeptal? Where do you access your transeptal? Do you cater more towards your PFA? Do you cater more towards LA closure? And then, of course, how do you image this into procedurally? Now, my case is going to focus on a TE guided workflow. Of course, the other workflow is ICE guided workflow, and we've had Shephal Doshi talk about it during the symposium. And there are multiple different ways. And I think that the idea is that to have versatility and flexibility in your workflow, depending on what your center can do, depending on what you as an operator is comfortable doing. I think having good interprocedural imaging is extremely important to make sure that you have a good LA closure, because we obviously don't want things like leaks and device malpositioning. And of course, assessment of the device interprocedurally as well. So if we could go to my next slide, please. All right. One of the other things that always comes up with concomitant procedures is edema. So this is data that we presented at the AF Symposium this year on edema during pulse field ablation. And there's been more data that has been published since then with Mark Tam and his group as well. And the idea is that you actually get about 2 to 4 millimeters of change within or ostium of the appendage, not quite the orifice alone, but the ostium, because the ridge gets gets edematous and sometimes gets shorter when I guess it gets short and stubby is what I call it. And depending on what kind of device you're putting in or where you're going to put the device, it might matter. Also, depending on the type of PFA system you're using, if you're using a PFA system that's going to do a lot of intrapulmonary vein lesions like osteal lesions, olive lesions, etc., then we see that there's more edema when you do those kind of lesions in the left superior pulmonary vein. Next slide, please. And there have not been, again, I don't want to spend a lot of time on this, but there's not been a lot of trials looking at concomitant LA closure and PFA procedures. Of course, option had about 40% of patients had concomitant procedures, but that was thermal ablation. It's a little bit different, but there are two trials that are actually going to be looking at specifically pentaspline catheter and LA closure. So option A is a trial that's actually going to look at it in the Asian population, and then of course Align AF is a real world registry out of Disrupt, which is a registry that looks at the pentaspline catheter and the real world use of it, but also the real world use of concomitant procedures. If you could go to the next slide. And so let me introduce you the patient. So this is a classic patient that usually I bring in for a concomitant procedure. So this is a patient that has had a history of AF diagnosis for a while, multiple cardioversions. So in my mind, it's a patient that has persistent AF, maybe early persistent AF. Also comes as GI bleed, and so it's a patient that's otherwise a candidate for LA closure, has a high CHA2DS2-VASc score, is a high stroke risk patient, and needs an AF ablation as well. So both rhythm control strategy and stroke management strategy that cannot be an oral anticoagulant. If you could go to the video. So let's play the video, please. So if you look at this, you can see I told you I'm doing the imaging with TE in this case, and you can see we do 3D TE, which is I think to me the standard of care for these procedures. I get all of my access with ultrasound. I think in today's world when we start talking about safety, I think one of the things that we have to be careful about is vascular access because these sheets are bigger. You can see I'm using a Perclo system here for hemostasis, and I tend to send my patients home the same day. I do use intracardiac echo 2D ICE for my PFA. And this patient did not have any pre-imaging, so I'm using 2D ICE. And since I have TE, I'm not using a 3D ICE catheter. And you can see I'm getting my SVC here. So here, for our audience, I've actually put color on there to actually show you the SVC. So this is a retroflexed view. Here's your left atrium. You can see the SVC. And so I'll make sure, especially if their patients have leads, et I will actually put the color in there, just check on to see that my transeptal is not interacting with the leads. And here I'm dragging down to the septum. In this patient, it's got a little bit of kind of a posterior takeoff with that TE. So I did like a inferior mid kind of stick here. So I'm coming and I'm actually taking my ICE catheter into the left atrium, which is my workflow for PFA. Now, this is not something I'm doing for my particularly for my LA closure, because this is a TE guided LA closure. But you can see the ICE kind of gives you real good visualization of that left atrium, that pulmonary vein. You see, I put the wire into the pulmonary vein. And here, what we're using is we're using a new contact sensing software that is available with the Opal system. And once you actually rotate it in the flower configuration in the atrium, it kind of standardizes it to the blood pool impedance. And then the idea is that when you have contact, your splines will light up and you can see which splines have contact. So especially when you're using 2D ICE, it's a little valuable. You don't have to keep rotating back and forth to see if all splines have contact. You can actually use the system to tell you have contact. But again, if you look at this image this is ICE in the left atrium, looking at contact of that basket catheter in the left superior pulmonary vein. And here I came from basket to a flower configuration. You can see I did not do olive lesions in this case. Number one, because the pulmonary vein sleeve was very short. and there was no reason. I was able to get what I needed to get with my basket configuration. If a sleeve is very long, I actually will do a olive lesion, or if I'm planning on a mitral isthmus line, I'll do an olive lesion. But I don't do olive all the time, especially in a concomitant patient. I try to avoid olive if I can, if I don't need it. So here you can see we're doing that volumetric analysis. So as that blue clouds come in, that's a volumetric analysis of how the catheter is intersecting with the contouring of the left atrium, and you can see the splines lighting up, with showing contact. You can also see on ice. This is like the retroflex view appendage on the top here, a pulmonary vein on the bottom, clearly showing contact of that spline onto that anterior ridge. And for the panel, please go ahead and chime in. I'll let the video kind of play along, but you can see, and feel free to interrupt me as well. Here we are going into the left inferior pulmonary vein. You can see the wire going in. Of course, the Opal system does show you the wire as well. You can tag the wire, but unless you create a shell, it doesn't highlight the wire like the Insight system will highlight the wire ahead of time. You don't have to have a shell, but you have to kind of create a little bit of geometry with the system for the wire to get picked up. So here you can see, I like to use ice to make sure I have the wire going into the vein. You can see this particular vein, that basket is just sitting at the orifice, not really deep within the vein. Here you can see nice contact of the flower configuration on the left inferior. And you can see I'm not really doing the 4 and 4 application that is kind of advocated with the Farapulse system. I'm doing a very segmental approach. So you can see in the superior vein, I did my ostial lesions with the flower, and then I actually did a carina lesion that is specific. I tilt down the sheath and do a specific carina lesion, and I'll do the same thing here. You can see I take the deflection off of my sheath, and I'm addressing that carina. With the spline sitting right on top of the carina there, and along that anterior ridge. So, Shephal, I'll bring you in, and just kind of, what is your workflow? Are you doing just the 4 and 4 and moving on, or are you doing a more segmental approach since you now have pretty good understanding of where those lesion tags are falling?
Yeah, I mean, I think I'm doing a little bit of both. I think there's certain areas, or at least I found early on, where either my lesions were either too osteal or maybe there was some reconnection. So I tend to do some consolidation lesions kind of at the anterior aspect of the right upper kind of roof, and just kind of hit it with two more applications there. And then sometimes, I mean, if there's a big space in the carina, I'll definitely keep the wire in the upper and deflect kind of more down and septally to kind of make sure I'm not missing anything, because we're not really high density mapping with these catheters in case there's
Yeah.
some electrograms left. But I want to make a comment. You showed a really nice image on
Can
the
I
upper
show
vein where you had the petals laying right on the Coumadin ridge.
Hey, well,
And
can I pause you for just a second? I just want to highlight one thing. So for the right superior vein, which is what we're doing right now, if you see on the map, you can see it. But one of the ways to identify the right superior vein and know that you're in the right superior is looking at the pulmonary artery and looking at your proximity of the splines to the pulmonary artery. And this area right here, along the roof of the pulmonary artery, along the roof of the right superior, is an area where you actually have reconnection. So here's a pulmonary artery there, and I always make sure that I have good apposition of that spline to that area. So go ahead, Safe. I'm sorry. I wanted
no,
to
that's
not miss that area.
the point I was making earlier. But I was saying, you showed earlier a really nice image of the petals laying on that Coumadin ridge, and you can see edema forming on that. And I think that's where left-sided ice is really nice, because you can see in real time as you start ablating that area getting really thick. And if you have a very short ridge, then sometimes that could have implications on how that device is going to sit, especially if you have a shallow appendage. So your images
So here,
pre-procedure, I think, were really nice for that.
yeah, here, this is the right inferior vein. Again, it's sometimes hard to image the right inferior vein from the right atrium, unless you're in the SVC sometimes, or low IVC. But here you can see the imaging on the right inferior vein is very good. Clearly shows you what the inferior border of that right inferior is. Sometimes on the right veins, when the pentaspline catheter comes, I think it always almost sits in an off-axis view. It's never on falls, especially in the basket configuration. So I almost always try to get a nice on falls application with the flower configuration. I don't trust the basket configuration to give a nice even lesion in these areas. I think the way we come with the basket never works that way. And here you can see I'm doing a very kind of segmental approach again. There are many folks actually that do just basket lesion for the superior and the inferior first, and then just stamp with the flower around. But I like to do each vein separately, but still stamp. Here I'm actually, because I'm taking the kind of the posterior roof away, and you can see the pulmonary artery there. You can see the flower on the ice kind of nicely having contact on that roof. This is an area, if you're going to do it, you want to make sure that you have good overlap, you have good contact, because it will reconnect and set yourself up for reentrant flutters. So you can see I'm actually stacking. One view I do want to focus on here, you can actually just do lesion tags, or on the right here, you can see this AP projection, or kind of the floor up projection. And what I'm looking at is I'm looking not just at the shadows, which kind of get overwhelming, is I'm looking at these shafts of these of the pentaspline catheter. And it's almost like I'm looking at the dots to make sure that I'm evenly spaced and I have good overlap, because to me, this is an area that requires more overlap than just 75% overlap. I think it requires probably 50% overlap, and in maybe different orientations. David, I want to just kind of bring you in and ask you what your workflow is for the non-PV areas. And you can see here we did PVI, and not quite the posterior wall, but the posterior roof for that matter. But I just want to focus a little bit on how wide my PVI is, how wide I came anteriorly on the right side and the left veins. And I think we are, if you can pause the video for me, that'd be great while we have a little bit of discussion.
Thanks, Debbie. Yeah, these are really nice images, and I think they're very instructive. You know, when we do the veins antrally, we always have to have a sense from the anatomy whether or not it's going to be necessary, or, of course, our desire to
Oh,
isolate the
hold on.
posterior wall as
David, hold
well.
on. Can you pause the video, please, guys? Can you pause the video? Okay, perfect. Go ahead, David. Sorry.
And I think I completely agree with you. The roof area is really the thickest part of the left atrium, and traditionally this is an area where reconnections or channels can form. So heavy overlap in that area is always desirable. I think on the lower margin posteriorly, if we're taking a sort of a broad posterior wall ablation, we can extend the spacing a little bit if we're trying to keep our lesion count down, for example, in someone where we're doing a lot of ancillary ablation, or if they have renal failure, and we're trying to minimize any potential for hemolysis. So yes, I think that we have to ablate the roof quite thoroughly.
Yeah. Mo, any thoughts from you on the workflow for PFA before we move to the LA closure part?
Yeah, actually, you demonstrated it beautifully. On the posterior wall, yeah, when we're doing the flower, it's really hard to have all the flower in contact actually with the posterior wall. You're only going to see that the petals that are closer to the septum are in contact. So this is where you have to make sure that you are quite overlapping, especially if you're going down. If you're hitting that posterior roof, you have much higher chance that all the petals are going to be touching. But as you come down, as David mentioned, you want to make sure that also you have a good overlap, because only the septal petals are touching. And as David mentioned, is like that roof is very thick. So sometimes what I do actually a 3 lesion sets, because with 3 lesions, you can still get a slightly deeper lesion than with the 2 applications.
Agree.
I made one
All right.
comment, Debbie. I think, you're very experienced with doing this, without fluoro. And I think what's great about the way you show it is you're not actually forsaking any imaging. You're able to see everything very, very well. And I think for some people who are trying to learn the technique, it's really important that you don't want to just do no fluoro just to not do fluoro. You want to really be able to see everything the way you can. So I think there's a little bit of learning, but I think the importance, I think, that you've showed all of us is having that ice on the left side really is a game changer, because trying to do this from the right side is really challenging to be able to see everything so clearly.
Yeah. If you can play the video, please. We'll kind of move along in the interest of time. All right, there you go. So now we're moving on to the appendage closure. And so I actually put the VersaCross wire back in, and I like the True Steer sheet. I use a steerable sheet for all my LA closures. And you can see the angiogram. I don't use a pigtail. You can see our transeptal is, you can see um, that posterior takeoff of the appendage. And this is one of those reasons why I think the transeptal was important to not, I mean, I could have gotten away with an inferior one too, but you can see we're coming in pretty coaxial there. I like to enter in 3D like I showed. Here we're coming in with that steerable sheet. And the beauty of a true steer sheet is that you can do mid-deployment steering. And I'm actually extending the sheet or deflecting it up as I'm deploying to get a nice coaxial alignment. You can see this is a 31 millimeter device, and you can see the angiogram there. Very slow deployment. This is a sped up image almost, but very important to have a very slow deployment. You can see the RO markers are pretty in line. Of course, I'm using fluoroscopy for this one. So just because I didn't use fluoroscopy for the PFA, I've come in with my little shield. And for me, I think that is an important thing. I think there are things about LA closure, even though I can see the appendage very well from the ice in the LA, I do believe there are things about the device on fluoroscopy, like how it opens, how the struts open, how the angiogram looks, that are very important for me to make sure that I've done this procedure appropriately and adequately. So coming back to the panel, there is thoughts about, I had questions yesterday about why didn't you just use just ice for your LA closure? And not, why did you bring in fluoro? I still feel like there is value in fluoroscopy in LA closure. As much as I'm a proponent for no fluoro, this is one thing I still use fluoroscopy. And it's very tiny, but it's still there. I want to just kind of see what the panel thinks about it.
I think, thank you, Debbie. Go ahead. Sorry, Debbie.
No, go ahead, Mo, please.
I was just saying, you're right. The fluoroscopy is important just to see how the device actually opens up. So I actually don't use a lot of angiography, especially when I'm doing PFA for the same concern that we're worried about renal dysfunction. But I can rely mostly on TE to deploy. But I really like the fluoroscopy when I decide on the size of the ball. I like fluoroscopy when I'm actually trying to use the sheath, the deflectable sheath, to try to steer to the watchman. And more importantly, I want to see the last image of the watchman. I want to make sure that the distal portion of the watchman is not over compressed. I want to make sure that the anchors are well attached. So this is where probably I use the fluoroscopy, but I think we can use also TE or ICE to deploy that device.
Yeah. I think
I have one comment to that.
David,
I think
yeah.
one of the limitations of ultrasound is seeing the depth. You know, you can see that, especially with ice, you can see the ostium very, very well. But in ice, it tends to look always too proximal. And when you have fluoro and you can see the distal puck is in deep, it gives you more of a sense of comfort, which you can't really appreciate when you're doing no fluoro at all. Especially now we're gauging the size on the length of the device, not so much the ostium. We want a long device that sits as far back as it can sit. As you beautifully showed, it filled the whole appendage in length. So I'm a big proponent of having, and you know, when we give contrast, even with renal dysfunction, we're giving 10 cc's. We're not giving 100. So if you need to do one shot just to kind of make you feel comfortable, you shouldn't shy away from it.
Yeah. David, any final thoughts before we close the session?
So our workflow has moved to 100% 40 ice with concomitants. But I think it's really important not to compromise on the imaging. So we've really brought back the pre and post ejection. So 2 injections for each patient. And I think you have to bring your resources to bear. I think we're very used to and trust TEE. When we graduated to ICE with our concomitants, basically just for workflow issues, what we really wanted to bring in is make sure we had our pre-procedural imaging in line, which gives us confidence that we know what's there. And we do use some fluoro during it with the injections. And I think that when we bring all those together, I think our confidence on ICE only workflow has worked really well. So, but I would not give up. You know, we experimented with Zero-Fluoro Watchmans as standalones, just using TE, and it's quite feasible in most cases. But I was not so confident on ice only because I think the one thing we must agree on is we cannot compromise the left atrial appendage closure procedure. It has to really still give a full importance. It has to have equivalent outcomes. Otherwise, we're doing a real disservice.
Yeah, I agree. So we're about out of time, but thanks to our great panel, Shephal, David, and Mohamed. For the next
Thank you.
session, the focus is robotic surgery, starting in just a minute. See you there.